Hello, everyone. We're back to talk about precedent on admission and what that means and how it impacts DRG reimbursement. Precedent on admission indicators are used to indicate what types of diagnoses were present when the patient was admitted. Precedent on admission has now evolved to the point where it's a one character indicator that's reporting the status of a diagnosis at the time that the patient's admitted to the hospital. CMS has put this out in publication 100-04. Precedent on admission is being defined at the time that the order for inpatient admission occurs. So any condition that develops after that, including the emergency department, is considered present on admission. So why do we care about this? Basically, CMS is looking at present on admission as some type of quality measure. So if somebody's admitted through the ER, they're transferred in from a SNF, and they have bed sores that are being treated during their hospitalization. If those bed sores were not documented as being present on admission, it's assuming that the hospital is responsible for them and that they developed when the patient was in-house. And as a result, CMS is going to hold back reimbursement for that hospitalization tied to that treatment. And the flags, as we call them, are basically as described here. Yes, it was present on admission. No, it was not present on admission. It was unknown if it was present on admission, because sometimes patients will go from one acute care setting to another. And W is clinically undetermined, and 1 is exempt. Some complications are considered exempt from these indicators. Hospital-acquired conditions are basically conditions that develop once the patient is in-house. This can also be referred to as a nosocomial condition. And how this relates to everything else is a DRG, or the diagnosis-related groups. DRGs came into being in the 1980s, and DRG is the way we still refer to them, although they've now been refined a little bit. And basically, they're diagnosis-related groups. So this is a kind of prospective payment system that's reimbursing hospitals for inpatient services based on like diagnoses. So what determines it is the principal diagnosis and some other factors, as we'll see. And now, of course, we always think of DRGs as being solely in the acute care hospital setting, but you can see them expanded. So now we're seeing them get into long-term care and other different types of refinement, the Medicare severity, APS, all payers refined, severity DRGs, but basically they're types of classifications of hospitalizations that are related to the diagnosis-related group. So what, may you ask, determines what DRG? It's the principal diagnosis. So in other words, the principal diagnosis is the condition that's established after study to be chiefly responsible for occasioning the admission of the patient to the hospital. That is the principal diagnosis. Note it says after study. So if somebody comes in with shortness of breath and we work them up, we determine they have COPD. COPD would be the principal diagnosis. And that was okay for a while, but years have gone by, and now they're saying that not every hospitalization within each DRG was being reimbursed appropriately. So then we had a way of kind of parsing it out, and that's due to complications and comorbidities. A complication is an unexpected event that develops as a result of the treatment during the hospitalization. And a comorbidity, or a major comorbidity, is more resource intensive. So a comorbidity is a separate condition that's present. This is different than a complication. A complication is something that happens while the patient's in-house. Comorbidity is something that they already had. So if we have our patient with COPD again, and they had diabetes and other issues, the diabetes would be the comorbidity. Major complications and comorbidities, or MCCs, are those that have an impact on the treatment of the patient. So they're more resource intensive. Therefore, the hospital deserves to be reimbursed more for a patient within the same DRG that has an MCC, a major comorbidity or complication or comorbidity, excuse me. Now, the last thing we want to look at is the Uniform Hospital Discharge Data Set. This is basically data fields that are common to all acute care and other designated healthcare facilities. We're seeing them now in long-term care and others. It's basically those types of things that you used to see on a face sheet. So what do we need to know about this with coding? One of the reasons that hospital coders are paid and very well compensated is because they have a significant bearing on the reimbursement the hospital receives. By picking up major comorbidities, complications and comorbidities, they move the hospitalization to a higher paying DRG. To get within the right DRG itself, they need to have the correct principal diagnosis. Anyway, that's all I have on this chapter. We'll look forward to seeing you online. Feel free to stop by office hours if you have any other questions or concerns. We'll see you online. Bye now.